And here's weeks, and it doesn't matter whether it's Jen, Jennifer, I'm very laid back about that. While I am the chief executive of the International Association of Forensic Nurses, I am a forensic nurse myself. I've been a nurse since 1986 and a forensic nurse by trade since 1995. So that really started as a sexual assault nurse examiner and then moved to serving many more populations, from intimate partner violence to trafficking and strangulation, child abuse, etc. So I have a long history of actually working clinically, but I have been with IAFN since 2011, initially coordinating some grant projects with them and the education department, and now as the chief executive. But as you can see, I try to keep my hands also in the work and teaching and so on and so forth. So with that brief introduction, today we're going to talk about sexual assault in intimate partner relationships, and this is a grant supported training. So my goal is that everybody walk away with some increased knowledge related to what sexual assault in intimate relationships really looks like, and hopefully how to effectively respond to it when you know what's going on, and perhaps from a health perspective, if not advocacy and other perspectives. So I'll start with that and say that for the purposes of this training, at least, using the Centers for Disease Control definition of intimate partner, which is really a person who one has a close personal relationship that can be characterized by emotional connectedness, regular contact, ongoing physical contact, and sexual contact, often identified as a couple, has familiarity and knowledge about each other's lives, but it doesn't necessarily need to involve these specific dimensions. More importantly, really, intimate partner relationships can be former or current. So people who are married or common law spouses, civil union spouses, domestic partners, boyfriends, girlfriends, dating partners. We see a lot of intimate partner violence in the adolescent population, and ongoing sexual partners. But they don't necessarily need to be cohabitating, so they don't have to live together. It doesn't matter whether they're of opposite or same sex, and sometimes it can be that they just have a child in common from a previous relationship. So we do see a fair amount of former intimate partners who one partner experiences intimate partner violence in the form of sexual assault sometimes and sometimes not. So with that sort of foundation laid, while this illustration is fairly old at this point, I put it in here because it doesn't seem to change with time. Unlike that horse I mentioned trying to get to the finish line, if there's a finish line at all, it should be that none of us has to live with any type of violence. But this image really shows what sexual assault really looks like. So typically, data that we collect on sexual violence comes from police, clinical settings, sometimes non-governmental organizations, and survey research. But the data that we collect and the actual prevalence of sexual violence is often likened to what you see here, which is the iceberg effect, right? So we see at the top part of the pyramid, really, the sexual assaults reported to police, and below that, the sexual assaults reported on the survey data that has really become critical, I think, to the work of healthcare and advocacy for sure. And then below that surface is really all of that sexual violence that is not disclosed for any number of reasons. Oftentimes, shame is part of that. It can also be self-blame. It can be blamed by others. so many of you do this work, you know all of the many reasons why both women and men do not come forward to report their sexual violence. Oftentimes it's a systems response type of thing where victims simply cannot bear the concept of entering the systems that we have established in this country to address sexual violence, at least not from a criminal justice perspective. So we're looking at the top of the iceberg, but we're also trying to address all that is going on below the surface. And the prevalence of sexual violence is so much higher than I think the general population realizes. Surveys of victims of crime happen all over the world, really, from cities to countries. And this is really from the World Health Organization. You can see by region where the prevalence of physical or sexual violence is taking place by a partner and by a non-partner. But you can really see areas of the globe where this is a huge issue. So despite all of our work, and certainly we are making progress, so there should be no shame in the fact that we haven't eradicated violence, but we're making progress, but the numbers are still really, really high. When it comes to things like marital rape specifically, marriage doesn't provide consent for sexual activities, and consent cannot be assumed between or among intimate partners simply because there's a marriage in place. And believe it or not, this is a relatively new concept. Research alone, not taking into consideration the below the iceberg portions of what we know, the research alone shows that women who have been sexually assaulted, 20% were assaulted by a spouse or a former spouse, and an additional 4% by a current or previous cohabitating partner. Now, that is old data, but the data remains consistent across time. And what I will say is, from at least from my own clinical practice, and I have practiced in both rural and urban high volume areas for sexual violence, on average, when it came to spousal or intimate partner sexual assault, somewhere in the neighborhood of 30% of the patients we took care of fell into this category. They were sexually assaulted either by a current spouse or partner or a former spouse or partner. So very high numbers. And the thing is that across the board in sexual violence, whether you're talking about intimate partner violence, sexual violence, or sexual violence at the hands of someone who is not an intimate partner, there are short-term and long-term, both physical and emotional or psychological consequences. And those are the things that, at least from a nursing perspective, we worry a lot about, especially as we try to convince healthcare systems, healthcare administrations, even the criminal justice system, that sexual violence is a health issue. So you'll see me refer to that quite a bit as we talk about this. But since the 1970s, in the 1970s, right around the time of the development and birthing of advocacy across this country, marital rape began being recognized as a crime versus something that was considered part and parcel of being married. So it's now illegal in more than 150 countries, including Canada, the United States, throughout Europe. But as of 1993, so less than 30 years ago, all 50 states legally recognized that sexual violence can happen between married couples. However, 13 states still make legal exceptions for marital rape. The most common exceptions require that force be used in order for a victim to bring a case against their spouse. Now, on federal lands, there are no exemptions from rape prosecution granted to husbands. So we've come a long way, right? But that entire country should really be grayed out at this point, and we shouldn't be having exemptions. The American Indian and Alaska Native population is by far the hardest hit when it comes to physical violence, intimate partner violence, and sexual violence. According to the National Institute of Justice, more than 4 in 5 American Indian and Alaska Native women and men have experienced violence in their lifetime, and more than 1 in 3 experienced violence in the past year alone. These women are 1.2 times as likely as non-Hispanic white women to have experienced violence in their lifetime, 1.7 times as likely in the past year. So the numbers are staggering. And while this is, again, research, and so we're not really getting to underneath the iceberg issues, some of the work that I've had the occasion and really blessing to do in a variety of different Native communities, in talking to groups of Native women, if I think about the conversations that I've had in groups of Native women, the numbers are much closer to 100% of the population having experienced either intimate partner violence or sexual violence. Never mind a combination of the two. So it is a population that is near and dear to my heart, and we try very hard at our organization to make sure that we do our best to provide education, training, technical assistance in those communities that are looking for that information. The same population are more likely than other racial groups to be seriously injured during this type of violence. Oftentimes, if I go outside of the American Indian, Alaska Native population of patients that I've served, probably thinking about physical injury of victims, sexual violence victims specifically, the most physically injured victims that we ever saw in clinical practice were intimate partner violence sexual assaults. Hands down, they had the most physical body injury as well as genital injury that we saw. And in the American Indian and Alaska Native population, those rates are even higher. So it is common and necessary that victims in all populations, but specifically this population, require medical care and have access to medical care. But the truth of the matter is that while this population is more seriously injured than other populations, they're also less likely to have access to the needed services. So that is an issue that we feel very concerned about. But when I think of Alaska, there are so many challenges to some of the rural villages and communities that it can make it really, really difficult to find the care that is necessary, and coming up with unique solutions that meet with what the community says it needs are critical. The other issue to consider in intimate partner sexual assault is that estimates of lifetime sexual assault really range from 15 to 85% for lesbian or bisexual women, 11 to 54% for gay or bisexual men. And again, sometimes the research, whether we like it or not, is old for us to look at here. So it's really important that we have as much up-to-date data as we can gather in an effort to identify where the greatest services are necessary. 52% of participants in one study of sexual coercion in gay and lesbian relationships reported at least one incident of sexual assault or coercion in their lifetime. So this is a population equally at great risk for sexual violence in their intimate relationships. In this same LGBTQ community, patients who identify that way experience rates of intimate partner violence similar to or higher than people who are in cis relationships or non-LGBTQ relationships. And according to the Coalition of Anti-Violence Programs, who did a report on lesbian, gay, bisexual, transgender, queer, and HIV-affected hate and intimate partner violence, the severity of IPV violence reported in this community rose dramatically when they compared it to the available data they had in 2016. Now, that may be because people are becoming more comfortable with reporting what has gone on. It may also be because we collectively as a society are getting better about finding ways to access relatively underserved communities, and the LGBTQ community has been vastly underserved when it comes to identifying and addressing violence in those communities. Healthcare providers, again, so that's my perspective. I'm sure many of you have other perspectives. Some of these statistics that we're looking at today from the CDC are really, I feel like, staggering. So 43.6% of American women, 24.8% of men report contact sexual violence at some point in their lifetime. Oftentimes, particularly as it relates to men, we hear lower numbers of sexual violence reported. And I think while there is stigma and shame attached to women and girls coming forward to report sexual violence, I think that is exponentially greater for men and boys for a whole host of reasons that I'm sure all of you are familiar with. This graphic just sort of outlines what I said before, which is most American Indian, Alaska Native adults have been victims of violence at some point in their lives. Men and women are victimized at similar rates, but in different ways. So while psychological and physical aggression rates by intimate partners are similar, sexual violence and stalking is committed in higher levels against women, which makes some intuitive sense. And the percentage of victims, women and men, who experience violence by non-Indian perpetrators is also staggering. So all of those things have to be things that we consider as we try to create services and interventions and ways in which to address the violence in various communities. And I'm a big proponent of being very community specific, because what works in one community is not necessarily going to work in another. And those of you who are in Alaska, for sure, you know this is true, because you have a different array of challenges than folks in the lower 48 do. Being in a relationship, though, does not protect anybody from being sexually assaulted. It happens frequently in relationships. And in fact, I worked with a gentleman who provided batter's intervention, and he once told me, and of course this is anecdotal, it's not in a research study, but he once told me that in the batter's intervention groups that he had conducted over the years, every one of the groups, they included a question on whether or not the person in treatment for batter's intervention had either sexually coerced or sexually assaulted their intimate partner. And he said 100% of the groups of batterers that he had worked with had reported sexual assault or sexual coercion in order to injure their partner. So, and again, it's important to remember that the LGBTQ community also is impacted greatly by this. So lifetime victimization rates, again, much higher for American Indian, Alaska Native women and men. And compared with women who experience a rape by a non-intimate partner, women who experience rape in the context of a marital or dating relationship were much less likely to blame themselves or the perpetrator for the assault, in part because they were less likely to label their experience as rape. And one of the things that across the years, I feel like I've been semi well educated by the folks that I have had occasion to work with and train with. And one of the things I learned in one American Indian community was they didn't even really have a word for rape or sexual assault. That wasn't really part of their language, so it was difficult for them to put into words what they were experiencing. And I think those are the kind of things that it's so beneficial to learn across the years when you're working with folks, so you can determine what they need and how best to serve them. Because the research, you could sort of drown in the research that exists on intimate partner violence and on sexual violence, but there's still inadequate research on certain aspects of vulnerable populations outside of women of childbearing age. And nurses in particular, obviously I'm a fan being a nurse myself, but nurses in particular make up millions of the providers caring for patients in clinical settings. They are perfectly positioned to screen, assess, and offer interventions in all populations where intimate partner violence may exist. That's why the Emergency Nurses Association, in conjunction with the International Association of Forensic Nurses, released a position statement, this is back in 2018, on intimate partner violence. And in it, part of the position, which is readily available online, but said that emergency nurses and forensic nurses routinely and consistently and privately should be screening all adult and adolescent patients for intimate partner violence. Whenever there is screening for intimate partner violence, there should be follow-up screening for sexual assault, in the sense that if you talk to somebody and they indicate very clearly that they're in a violent relationship, one of the things you want to get clear is sexual violence part of that overall intimate partner violence? The health concerns, which I sort of mentioned, there being both short-term and long-term health consequences for survivors. On the left-hand side of your screen, you can see a sampling of some of the health impacts for patients who experience sexual violence: pregnancy, transmitted infection, HIV and hepatitis, depending on the community you're in, genital injury, other body surface injury, pain, both short-term and chronic pain. It's not uncommon to see patients who have chronic pain problems have learned that they have had a history of intimate partner violence, clinical depression, suicidal ideation, and exacerbation of pre-existing conditions. So if the person has, say, asthma, sometimes having an intimate partner violence episode at home can exacerbate that condition. Or we find batterers take medication from the person, prevent them from taking their medication for their chronic diseases. So they may have diabetes that has gotten out of control because they no longer have access to their insulin because their partner threw it away. Long-term health impacts, which is why we like to get people into a health system that can work with them, include some of the same things: ongoing clinical depression, but also PTSD, conduct disorders, substance abuse, suicide attempts, tuberculosis, which has a lot to do with untreated underlying disease, often because their partner won't let them access care, urinary tract infections, pelvic inflammatory disease, often brought on by sexually transmitted infections, many reproductive issues, and again, pre-existing condition problems. So there are many health issues associated. In one particular study, victims identified medical care as the most commonly needed service following IPV and IPV sexual assaults. And yet 38% of them in this one particular study were not able to obtain the services they required. And again, for healthcare professionals, this is the piece we should be very concerned with. We should not have patients needing care who can't access care. Sometimes they can't access care because there's none available in their village. Sometimes they can't access care because their partner won't let them leave to access care. Sometimes they can't access care because the care service is tied to some other system. Maybe it's tied to a mandatory report by a healthcare provider. And so they know if they go seek care, law enforcement is going to be called, and that can be a deterrent for some people coming in to seek care. Certainly one of my goals is utilizing forensic nurse examiners. So forensic nurse examiners are nurses with specific education and training to provide specialized care for patients who have health consequences associated with violent victimization. And they may also have evidentiary needs. So intimate partner violence, sexual assault victims who come in seeking care may also require evidence collection, and they need to have those options available, whether they want it or not, right? They need to have all options available. So if an IPV sexual assault patient comes in and says, I don't want to report, I don't want evidence collection, but I do want to make sure I don't get pregnant, and I do want to make sure that my injuries get treated, that they have that option. In addition, forensic nurse examiners obviously provide both consultation in healthcare settings and testimony for both criminal and civil proceedings. So they testify to what the patient said, what they saw, what the findings mean, the care that was given, and oftentimes as an expert witness to what their opinion was regarding those findings. And that is part of their training. So some people refer to them as forensic nurse examiners. Others have sexual assault nurse examiners specifically. Either population of nurse should be able to take care of an intimate partner sexual assault. We train on this all the time. The nurses do not, nor should they, view themselves as an extension of law enforcement. Having said that, society sometimes does. They think that they can split it down the middle and part of you is a nurse and part of you is law enforcement. That's not the case at all. All of you is a nurse. So, so even though society at large views us as an extension of law enforcement, we don't see ourselves that way. We are nurses, and while we do take care of patients that may end up inside the criminal justice system in one way or another, our job really is to educate patients on their reporting options, collect evidence where the patient wants us to or where it's necessary, document exactly what has happened to that patient, including the findings that we see, and ensure that the patient gets the proper care that they need. And sometimes that care is in the moment with us. Sometimes that extends into follow-up care needs. Sometimes we see patients back in follow-up too to make sure that they're getting what they need. But it is absolutely healthcare. And one of the critical ways in which nurses specifically can impact the criminal justice system is through our testimony. And that is because we're healthcare professionals. Because if I acted like and did everything in conjunction with law enforcement, then the legal system could misconstrue that I was an arm of law enforcement. What I want the legal system to understand is that I am there for the purpose of diagnosing the patient in front of me for all of the things that may be impacting them. And that is what allows me to testify to what the patient said to me, what I found when I took care of the patient, all of those things. The medical forensic exam, sometimes referred to as the SANE exam, but it's not a SANE exam, it's a medical forensic exam. It might be conducted by a sexual assault nurse examiner, but it's a medical forensic exam, whether it's a doctor or nurse or SANE that does it, is really meant to be a timely exam following the sexual assault. And it includes things like getting the assault history from the patient, getting a medical history from the patient, documenting the exam findings, doing a complete physical exam on the patient, head to toe exam, as well as a genital exam in sexual assault cases. If the patient is within the window of evidence collection and they want to have evidence collection, collecting that evidence properly, handling it and preserving it, packaging it, etc., the way it's supposed to be, so that chain of custody can be maintained on that evidence and there's no question about where it came from by the time they get to trial, if they decide to report the crime. But also, in addition to that, evaluating and treating their injuries if they have them, or any other medical conditions that show up at the time of the exam, making sure that they have a support system in place that extends beyond that visit. So I consider myself only one cog in a full wheel of services that should be available to these victims. And that includes advocacy. If there is advocacy in the community that provides crisis intervention for that patient population, they need to be involved from the get-go. So at least the patient knows they're available. There's somebody they can continue to see if they need to. And any other, of course, follow-up medical care that they might need. It helps, in addition to that, to have working relationships with the law enforcement community if the patient is reporting. So there's some sense of what's going to happen next, because the unknown is frightening to people. In addition, the medical forensic exam includes prophylaxing the adolescents and adult population so that they don't acquire sexually transmitted infections following a sexual assault, ensuring that they have access to pregnancy prevention medication if pregnancy is a risk factor following a sexual assault. The nurses will interpret and analyze the findings for that patient, both at the time of the exam, but more importantly in court, so that a jury is educated and understands what the findings mean. And then giving testimony to that effect. Actual testimony if I did the exam, or expert testimony if I'm rendering an opinion on the findings that I found or on the findings someone else found. And then, of course, providing follow-up medical care for the patient's needs. For us, for our organization, the most successful components of any exam for any patient who has been a victim of violence is going to be that it's trauma informed and that consent and assent apply. So if an adult patient comes to see me, one of the first things they're going to hear from me is, you don't have to agree to anything you don't want to. All you have to do is tell me. I'm not going to do anything that you don't want me to do. So consent, as we teach it, is a process. It's not a form. Get a consent form at a healthcare facility, but that doesn't remove your ability as a human being to say, I don't want that. And it's the nurse's job to respect that all across the way. It's the nurse's job to make sure that the care that they provide is trauma informed, meaning you understand not only the trauma that happened to that person and its impact on that person, but trauma that may have come before. Sometimes the trauma, as you all know, is historical trauma. Sometimes the trauma is that not only were they sexually assaulted by their intimate partner, but when they were a child, they were sexually abused. being able to take into account all of those things and understand the impact that that trauma has had on that person's life, on their interaction with the healthcare system, on their health, on their health is critically important, because then you can provide adequate empathy to someone. The assent part is really meant for young kids who generally cannot consent to exams, and they can't consent to sexual activity, but they need to at least agree to have an exam. So that's what that's referring to. So our expectation is that whoever the responders are, whether they're nurses or physicians, or if there's some other clinician that's in play in your community, that the responder should be able to acknowledge and appreciate the whole patient, their whole experience, and be sensitive and inclusive in their interactions with that person. So, and that can range from all of the things I just described to making sure that if there is a limited English proficiency, that there are effective communication services for that person, whether it's because they're deaf or hard of hearing, or they speak a language that is foreign to the clinician, so that interpreter services are properly brought in, and the person that there can be effective communication with that person about what happened and what they need. But it's also important, I think, to understand the population that you're serving. If I was talking to a community group about what services they needed, I would want them to be educating me a lot more than I would educate them, because oftentimes the population that you're serving is going to be the population that can tell you what is life like in their community? What are the cultural considerations that should be taken into consideration as you're providing care? What needs to be provided that isn't necessarily traditionally provided in an American healthcare setting, for lack of a better way of putting it? And all of the materials and information that are provided to that person should be really inclusive of the patient populations being served, and accessible, so that they know what's available to them when they leave. So much, I think, of what we provide to patients is not geared toward what they actually need to receive, or it's not written in a way that is helpful to them. And sometimes we write more than we need to, and people cannot digest that, particularly after a trauma. Another thing that you'll see provided is, particularly as it relates to intimate partner sexual assault, is lethality or dangerousness assessments. In healthcare, we tend to use Jackie Campbell's danger assessment as an educational tool. For the patient, an educational tool; for us, a gauge to how long has this relationship been this way, and how violent is it, and how much in danger is this person. But lethality indicators for IPD sexual assault, really, they include, that estrangement from friends and family, unemployment of the offender, access to guns, having a stepchild in the home. All of these are pieces of the danger assessment. Forced sex. So anytime a patient is intimate partner violence, sexual assault, already that right there with nothing else, they're adding points on their danger assessment scale. Prior threats to kill the person, or threats with a weapon, especially when the partner is very controlling. So all of those things are things that we typically will include in our forensic nursing assessment. Another key component of Jackie Campbell's research is really that increasing employment opportunities, preventing substance abuse, and restricting abusers' access to guns can really reduce the overall rates of homicide and intimate partner femicide. And again, I know that's 2003, but that's back to the original research. So all of those things we should be considering, not only from the perspective of healthcare providers, but from the perspective of policy work moving forward. And another aspect of the care we provide is safety, discharge planning, and referrals. So any patient who is an IPV sexual assault patient shouldn't leave a healthcare facility without a safety plan. And the best safety plan providers there are the local crisis center advocates. I don't even think I could have done my job over the last 35 years without the work of advocates. And while nurses certainly can be trained in how to conduct a safety plan, usually if we bring in somebody to teach on how to create a safety plan with a patient, we use advocates to do that. They're very familiar with the community. They're very familiar with precisely what questions to ask. So if I was reviewing a record on an IPV sexual assault, I would expect to see something written in about what safety plan was created for that patient before they left the facility. The other thing that we really try to, and this is difficult, I mean, a lot of all of your jobs are difficult, but one of the more difficult aspects of training healthcare providers is really trying to get them to understand that part of their job is not to protect or save the patient, but rather help them create a safety plan. And there's a difference, because many healthcare providers will walk in thinking, well, you just need to leave, as if that is the solution and it solves all the problems, when in fact it doesn't solve all the problems, but sometimes it creates more. So IPV sexual assault is its own entity insofar as if you're caring for this sexual assault population, you really have to have fundamental understanding of IPV and just how tricky and dangerous and complicated and complex that it is. Children, family, pets, neighbors, friends, everybody needs to be taken into consideration as you create that safety plan and the discharge plan and the appropriate referrals for the patient. And, you know, one of the things that I try to point out, particularly to some of my healthcare colleagues, is that, you know, all of us at one point or another, I feel like, learned about Maslow's hierarchy of needs. And the idea is that you start at the bottom, but in order to make your way to self-actualization, you have to meet the needs of the bottom layers of the pyramid. So you have to have food, water, sleep, sex, you know, you have to have that typical normal things going on in your life. And then once you achieve that, safety, security of your body, which domestic violence victims do not have, security of employment, which can also be very tricky for domestic violence victims, of resources, depending on how remote you are, you may or may not have access to resources, safety of the family. If you have small children and you're worried about what is the batterer going to do to those kids if I leave, and what's the system going to do to me if I leave, what is the person's health, what do they even have, do they have someplace to go? That safety piece in Maslow's hierarchy is critical, because if you can't get there, and I would argue that if you're an IPV victim, you can't get there, you can't get to all of the things above it. And so it is up to us, really, regardless of our profession, to work toward IPV victims being able to achieve safety in order to move to those other places where they can have a stable, productive, secure life. And then I would also just point out that the CDC has several technical packages that are available on IPV, suicide, youth violence, sexual violence, child abuse, neglect. These packages all represent a group of strategies that are based on the best available evidence so on the research, to assist communities to focus on prevention activities to decrease the health consequences from violence. And one of the things that I'll say is prevention is primary, secondary, and tertiary. Everything in prevention is not primarily preventing it before it ever happens. Intervention as a form of secondary prevention is also critical to prevention at large, the larger prevention. So our goal really is, how can we decrease these health consequences? What can we look at these technical packages and see anything in them that might work in our given communities? And if so, which ones? But or can those systems be adapted to work in our specific communities so that we feel like we're doing something toward prevention? Again, keeping in mind that prevention is not only primary. So, and there's a list of references for you, and I'm going to put contact information up for you. And I see lots in the chat, but I don't read the chat as I go, so I want to apologize for that. And but I haven't seen any hands raised. So it's a super commonly seen issue, intimate partner sexual assault. And again, I would point out the most injured patient populations fall into this category. They're the ones that need the most physical care. And I believe all victims of sexual violence require some form of health care following their victimization, even if it's 4 weeks later or 2 years later, because of the long-term health consequences. But this particular population is very much at risk of physical injury and severe long-term consequences. So I will say that, and you're welcome to contact me at any time. Perhaps I talked too fast. I might have talked too fast. So have you had questions in the chat box that I've just been blatantly ignoring because it's impossible for me to do actually more than one thing at a time?
You've been fantastic, Jennifer, really, truly. And most of the stuff that you saw popping up in the chat is people wanting your PowerPoint. And we have and we have assured them that we will be sending out not only the recording of today's webinar, but also the PowerPoint with all of that information on it. Because I agree, attendees, Jennifer has a wealth of knowledge, and the statistics and information just chalked into this PowerPoint was fantastic. And a few of the things that I just want to comment on that really sort of resonated today was when you were mentioning the health impacts, right? The short-term health impacts and the long-term health impacts. Oftentimes it's easy to sort of forget about some of those things that are longer lasting, and paying attention to those things and knowing that as advocates and people on the front line, so we can be aware and know that those are in the way. And the other thing that you mentioned that I really appreciated too is that oftentimes healthcare workers, from the standpoint of a survivor or somebody just experiencing a trauma, it's easy for them to lump you into an extension of the law. So that distinction you made about we are not an arm of the law, we are healthcare providers, that's a beautiful distinction to make too and bring forward as we are serving the populations in the most needed spaces. So thank you for that. If there are any other questions, please feel free, guys, in these last couple minutes here while we still have Jennifer on the line. Otherwise, you can always email myself or anybody at Mending the Sacred Hoop, or Jennifer here has graciously given us her contact information as well. Honestly, Jennifer, wonderful. Thank you for all the information and your presentation, and your speaking style is perfect. Not too fast, not too slow, just right.
Thank you very much.
Yeah.
Thank you very much. Don't hesitate to reach out if you have any questions, for sure. And yes, you know, if you need anything beyond what is on the PowerPoint, just let me know, or you all can let me know. I'm happy to get it.
I just got a question in here from Terry to you. What is the most challenging aspect of your work?
Just one thing.
Right.
I think probably the most challenging aspect of the work right now, if I had to pick today, was that it seems to take a really long time to sort of infiltrate, that's not really the right word, but to infiltrate the healthcare system with the necessary and properly trained clinicians to care for these patients. That's from totally a nursing perspective.
Well, and that, that makes sense because of your vast experience, and you can only really truly understand something once you truly experience it, right? So when you're coming out of nursing school, it's probably difficult, to know exactly how to address these things. So as you're saying, yeah, filling it with knowledgeable people who haven't had the direct first person experience is, I can imagine, a huge challenge.
Yeah, but the work with the patients is so amazing. It's just amazing. And I know a lot of people come and go in the work, and there's a fair amount of vicarious trauma, but I'll tell you, there's nothing better from my perspective than seeing just the different expression on someone's face from the time they arrive, to start care, and from the time that they leave. There's just dramatic improvement in the expression on their face alone, because they realize they got through it and they were believed, and there is support system there. So yeah, it's great work.
I can imagine that's a beautiful thing, just relieving that emotional stress. You are getting so many pieces of kudos in the chat right now, people thanking you up and down and saying how amazing the presentation was. One more question. We have 2 minutes here left. So this next question says, did you have training in school regarding intimate partner violence?
No. I mean, first of all, I feel like I went to school 100 years ago, even though that's not true, but I'm highly over exaggerated. But no, I did not. But back in 1995, there was a push. There was a project funded as part of something called the Green Book Project, which many of you may be familiar with. And they funded 10 states. It was called the 10 State Initiative. And those 10 states were supposed to pull together teams of nurse, doctor, social worker, advocate, and law enforcement to come together, learn as much as you could possibly know about intimate partner violence and the proper healthcare response, incorporating those multidisciplines as well. And so in 1995, the state I was living in at the time was New Hampshire, and they were part of the 10 state initiative. And so I got to be on the ground trained on intimate partner violence. And that is how I learned the dramatic health impact. And as an ER nurse, I saw it. So, yeah, I mean, we talk about sexual assault, just generally talk about seeing sexual assault patients in, high population areas. What I try to tell nurses is, if you are seeing sexual assault patients, you easily are walking by 10 times that number of domestic violence victims in whatever healthcare setting you're in. Because until clinicians really learn how to talk to patients about it, how to really broach the subject in a way that's appropriate and confidential and without anybody standing there, much more like a conversation than some of what they suggest we ask, then we won't effectively identify those patients, and they won't know they can come to us for care, and they can come back. Even if they go into a relation, they go back to their batterer. The biggest message healthcare providers can give is, whatever you're choosing to do today, you can come back here. It's a safe place to come. You can come back here for care, and you can really tell us what's going on. So I was trained back in 1995 on IPD.
Thank you so much. Jennifer. One last comment in the chat, and then we'll bid adieu. From Beth O'Keefe is saying that her niece just graduated 5 years ago, and there's no discussion about IPV or sexual assault at all. And so this conversation needs to be had and had more often and had more deeply and integrated into the educational system. And hopefully we're on the cusp of that. Maybe that's the horse you came in as today is. Right, getting further along that racetrack, and maybe that'll be the next stopping point. Well, again, thank you everyone for attending today, and thank you again, Jennifer. I hope you all have a wonderful, I hope you all have a wonderful rest of your day. Take care.